It's nice to be here, and I appreciate this opportunity to talk a little bit about the implementation efforts around the federal health reform law and what we all at the department have been up to for the last couple of years. I think we would all agree that we are really in a unique time period in healthcare and are uniquely positioned to take action to improve the health of our population and reduce costs. We know the old system was unsustainable. We know in the past decade, premiums have grown 3 times faster than wages, and obviously that's not sustainable. So we at the Department of Health and Human Services have been hard at work over the last 2 years trying to address some of the imbalance in the system. A lot has happened in the last 2 years. I know consumers, insurers, and healthcare providers already have seen a number of changes. Changes in the way it affects their personal finances and the way that business is done. So I wanted to talk to you a little bit today about what we've done so far and kind of where we are and what's to come. And since we are here in Louisiana, I thought we could bring some of these statistics home by talking a little bit about how the people of Louisiana have benefited from the federal healthcare reform law. Health reform is providing new coverage options for young adults. Health plans are now required to allow parents to keep their children under age 26 without job-based coverage on their family's coverage, and thanks to this provision, 2.5 million young people in this country have gained coverage nationwide. As of June of last year, of 2011, over 45,000 young adults in Louisiana gained insurance coverage as a result of that provision of the law. The law is expanding access to preventive services. We know that getting the right preventive care, like cancer screenings and vaccination, is the best way to stay healthy. And in 2011, 487,000 people in Louisiana with Medicare received free preventive services, such as mammograms, colonoscopies, or a free annual wellness visit with their doctor. And 54 million Americans with private health insurance gained preventive service coverage with no cost sharing, including 719,000 people here in Louisiana. And that just doesn't help keep people healthy, which obviously is incredibly important, but it also helps to avoid costly hospitalizations, which we all know drives up costs for everyone. The law is providing better value for the premium dollar. Insurance companies must provide consumers greater value by spending generally at least 80 cents of every premium dollar on health care or improvements to care versus administration. And if they don't, they have to provide consumers rebates. The law created new coverage options for individuals with pre-existing conditions. The pre-existing condition insurance plan, also known as the National High Risk Pool, was created for people denied insurance or quoted extremely high rates because of pre-existing medical conditions. As of the end of 2011, 377 previously uninsured residents of Louisiana who were locked out of coverage before because of a pre-existing condition are now insured through the National High Risk Pool, and over 50,000 Americans have benefited from this program. The law provided for a consumer-friendly website. The federal government established a consumer-focused healthcare website at healthcare.gov. A key feature of this new site is the Plan Finder, where consumers and small businesses can now find detailed information in one spot on plans offered by insurance companies. They simply enter basic information and then see a list of all the insurance options available, broken down by how much they cost and the coverage they provide. If you haven't been to this website, just on a personal note, I would say it's a pretty amazing website, and I would encourage you to take a look. Children with pre-existing conditions are now covered. Insurers cannot deny coverage to children due to pre-existing conditions. And the law removed lifetime limits on health benefits. Individual and small group plans are now prohibited from placing lifetime limits on the dollar value of coverage, and insurers are only allowed to rescind coverage in cases of fraud. The law requires insurers to justify premium increases. Today, insurance companies must publicly justify proposed increases if they want to raise premiums by more than 10%. So that's kind of part of what we've done so far. Let's talk a little bit now about what's coming in 2012 and 2013. I'll talk first about essential health benefits. The Affordable Care Act ensures that health plans offered in the individual and small group markets, both inside and outside the affordable insurance exchanges, offer a comprehensive package of items and services known as essential health benefits. Essential health benefits must include items and services as specified in the law. In December, the Department of Health and Human Services issued the first, what we call EHB, Essential Health Benefit Guidance, on our intended approach to this issue, which is the option for states to select from among different benchmarks at the state level. This approach for 2014 and 2015 would provide a transition period for states to coordinate their benefit mandates while minimizing the likelihood that the state would be required to defray the cost of the mandates in excess of the essential health benefits. In the transitional years of 2014 and 2015, if a state chooses a benchmark subject to state mandates, such as a small group plan, which often is subject to state mandates, the benchmark then includes those mandates in the state essential health benefits package. We believe that this approach will accommodate current differences among the states, but we also indicate that we will evaluate this approach for the calendar year 2016 and will develop an approach that may exclude some benefit mandates from inclusion in the state EHB package beginning with 2016. After this bulletin, we heard from a number of stakeholders that wanted additional clarity on the essential health benefits, as well as some framework around actuarial value and cost-sharing reductions. So last month, we issued further guidance around those topics, and I'll talk about that in just a minute. But we also recently issued a frequently asked questions document on essential health benefits, and that is posted on our website. The questions and answers ranged from who in the state can make the essential health benefits decision, to clarifying the definition of plans and products, to further discussion on the substitutability of benefits within each of those 10 categories. So now I want to talk just briefly about actuarial value and cost-sharing reductions. I mentioned that we'd issued guidance on both of these issues recently. And the guidance really builds on the essential health benefits guidance that we issued back in December. As most of you in this room probably know, actuarial value is something that will be used by consumers to compare qualified health plans with different cost-sharing designs and as a way for consumers to understand relative plan value and coverage. The ACA directs the Secretary to issue regulations under which the level of coverage of a plan is determined on the basis that the essential health benefits are provided to a standard population. We intend to propose a standard data set for actuarial value calculations for qualified health plans and non-grandfathered health plans in the individual and small group markets, for which HHS will develop a national standard population. We did indicate that to promote state flexibility and to account for variations in price, utilization, and benefits across states, we intend to propose an option that would permit states to develop state standard populations based on state claims data. On the issue of making this data available and facilitating the actuarial value calculation, we intend to develop a publicly available actuarial value calculator that plans would then use to determine actuarial value. The calculator would be developed using a set of claims data weighted to reflect the expected standard population in the individual and small group markets for the year of enrollment. Plans would then input information on cost-sharing parameters. Both the logic and the tables of aggregated data used to develop the calculator would also be made public to promote transparency. We think this calculator method ensures a consistent set of assumptions and methods of actuarial value calculation, maximizing comparability for consumers since plans with the same cost-sharing design would have the same actuarial value. We felt it was important to issue this bulletin as quickly as possible to give stakeholders, like many of you in this room, an idea of our current proposed thinking with regard to actuarial value calculations and are now soliciting input on the proposed approach. The bulletin also outlines an approach to the payment for cost-sharing reductions. We intend to propose to make monthly advance payments of cost-sharing reductions to cover projected cost-sharing reduction amounts and to reconcile those advance payments at the end of the calendar year to the actual cost-sharing reduction amounts, and again, are taking input on that proposed approach. So now let's talk about the area I focus on the most, which is exchanges. Affordable insurance exchanges are really designed to make buying health insurance easier and more affordable. Starting in 2014, exchanges will allow individuals and small businesses to compare health plans, to get answers to questions, to find out if they're eligible for tax credits for private insurance or health programs like the CHIP program, and to enroll in a health plan that meets their needs. At HHS, we really start from the basic premise that we hope that states establish their own exchanges so they can tailor those exchanges to their own markets. And we're striving and working very hard to get states the guidance and the resources they need to do just that. Last month, we issued the final exchange regulations, establishing a framework to enable states to build exchanges. And under the rules, states have significant flexibility to create an exchange that best fits the needs and is responsive to the local market conditions. The exchange final rule includes standards for the establishment and operation of an exchange, health insurance plans that participate in the exchange, determinations of an individual's eligibility to enroll in exchange health plans and in insurance affordability programs, enrollment in health plans through exchanges, employer eligibility for and participation in the Small Business Health Options Program. The final rule builds on over 2 years of work with states, small businesses, consumers, and health insurance plans, and is really the latest in an ongoing series of steps that we're taking to help states develop exchanges. So where do states stand today with their progress in terms of establishing exchanges? We have 45 states that have performed background or market research preparing for an exchange. 44 states have initiated their IT gap analyses, and 38 states have finished those analyses. So 3/4 of the states have assessed their current and needed IT capabilities for establishing an exchange. 17 states, or about 30% of states, have moved or are moving to the next step and have drafted or are drafting business operating requirements for key functions. 15 states have an RFP issued or are in the process of issuing an RFP for a systems integrator, and 12 states are in the process of issuing an RFP for an exchange platform. And CMS has been working directly with states to support their efforts in developing business process documentation. States who have establishment grants can share draft process flows and business rules and RFPs in a collaborative online learning environment that we developed for states, and many states are using that now. Maryland, Oregon, and Washington have awarded contracts to their systems integrators and are starting development work with other states. 17 states have the authority to establish exchanges, either through an executive order or through legislation. And 23 states have developed or are in the process of developing a governance model, and 15 states have appointed their governing board. So next, I just want to talk a little bit about the implementation of the federal exchange, because I think that's where Louisiana is headed. So first, we have seen a lot of progress around the country in terms of states moving forward, developing their exchanges. But we also know that the timelines facing states are incredibly rigorous. And so we know that not every state will have the ability to get to a state-based exchange, and so we have to be prepared to step in with a federally facilitated exchange. To try and help states get there, though, we did recently announce that we've extended the schedule for availability for establishment grants to states. Under the new proposed schedule, states can continue to apply for grants through November of 2014 and spend that grant money after 2014 as long as the funds are used in the establishment of an exchange. So this means that those states that aren't ready in 2014, or states in a partnership model with HHS and who are performing some of the exchange functions, such as plan management, can continue to receive federal funding to facilitate that role. I should emphasize, and I think this is a point that I hear and get questions about quite often, these funding extensions don't mean that the deadlines have been extended. So the basic timelines that are in the statute remain, essentially the January 2013 deadline for certification and the January 2014 deadline for operations, or actually October of 2013 when you think about it. So the second thing I just wanted to mention is that we are moving forward aggressively in terms of establishing the federally facilitated exchange for those states that don't have certification in 2013, like Louisiana. Like the states, like many of the states, we have identified the key business functions that the federal exchange will support: eligibility and enrollment, plan management, financial management. And we've developed the business processes that define the sequencing and the interdependencies and timing for the core exchange functions. We're writing the business requirements that instruct the systems developers what they should build. And we've awarded our major IT grants to date, and we'll be awarding some supporting grants as we go forward. So as we finish defining our business processes and requirements, and with the recent award of the critical exchange IT contracts, we've begun developing systems to support them. We also awarded the contract to build and support the operations of the Federal Data Services Hub. The Federal Data Services Hub will provide IT functions to every exchange, regardless of whether it's a state-based exchange, a federally facilitated exchange, or a partnership model. The hub will be one single place that every state can use to securely validate the accuracy of information supplied by applicants with federal agency partners. We've also awarded all of our exchange operational contracts to manage the eligibility and enrollment strategy, operations and appeals, and to handle plan management and issuer certification. We've also awarded all of our financial management contracts to help develop the risk adjustment model, among other tasks. So you can see that we are making significant progress on the actual build of the exchanges, whether it's the Federal Data Hub or the development of blueprints for business processes in the federally facilitated exchange, or the work with states. And we're moving forward at a very quick pace because the timelines are very, very short. So as you can see, there's a lot of implementation work happening, and there's still some areas where we're continuing to finalize policies. We do expect to issue regulations soon on market rules, the rating rules, and guaranteed issue and renewability. And in the near future, as well, we'll have more guidance on the federally facilitated exchange and exactly what that will look like, and regulations on essential health benefits, actuarial value, and cost sharing. In closing, I would just say that we always try to keep our eye on the ball. I think as we are doing the day-to-day implementation work around the federal health reform law, it's really easy to lose sight of what we're working towards. So we often sit back and remind ourselves of really why we're doing this. And the big picture, I think, is this: we still need to fix the market. In the last 10 years, employer-sponsored insurance has declined. While 64% of the population was covered under employer-sponsored coverage in 1999, only 55% of the population had such coverage in 2010. And the percentage of individuals without health insurance is up for 2010, 16% in 2010 compared to 13.6% in 1999. But the Congressional Budget Office estimates that more than 14 million Americans will gain access to health care through the private coverage options in the exchange by 2015, and up to 22 million in 2016. Under the CBO estimate, 2 million more people will be enrolled in employment-based coverage purchased through exchanges beginning in 2014. We recognize that we have a ways to go, but we're very pleased at the progress that we are making and that we see states, maybe not Louisiana, but most states across the country making in terms of implementing the federal law. And I know many of you in this room are very involved in implementation efforts, and certainly want to thank you for all the work that you're doing in this area. And again, appreciate the opportunity to be here, and thank you very much.